All right. We're talking on pulley management. And so let's have a look, close look at the pulleys. So here is a cadaveric dissection. You can see the A1, A2, you see the cruciates as well, A3, A4, and A5 distal to C3. Okay, and S is the FDS tendon. And you can see how snugly the FDS tendon or the FDP is within the pulley. Here it's another view. You can see that the A2 is fairly thick, and A4 is less so, and A1. And this is the campus chiasma area. Again, the area is very tight. So we know that for A1, A3, A5, no issues, non-critical, it can be sacrificed if needed. And in fact, you should sacrifice it if you need exposure or gliding. As we talked as well, the previous teaching is A2 cannot be released completely, and A4 is also, if you excise it completely, then you will get bowstringing. However, I'm sorry, Dr. Lex, I didn't get your study, but by Moria et al., they released the entire A2 pulley, and it shows that it did not clinically affect the finger motion or cause any tendon bowstringing, provided that the other pulleys are left intact. And another study by Moria as well, in the same year, he released the entire A4 pulley, and it also suggested that there was no tendon bowstringing, and repair of the surgery is easier as well. So Abdul Malik et al. Mentions that releasing the flexor pulleys will allow better access and prevent impingement, and that's what we want, and also does not seem to cause bowstringing as well. So those are 3 studies in a row. So now we should say that the current recommendation is A2 can be released completely if A1 or A4 is intact. And for the A4 pulley as well, you can release it completely as well if the A2 is intact. Right, so this is the same slide which was shown earlier. So Jimbo Tang suggested to release 2 centimeters of any tendon sheaths to improve the repair strength and also the gliding as well. So the principle at the moment is that you should preserve A2 and or A4 whenever possible, and you must have the smooth tendon passage without excessive bulk. So you should use low profile, multi-strand core, epitendinous repair, any bulky edges, trim it, bury the knots if possible, consider Walland surgery, and have an active motion protocol. However, if you have your A2 and A4 lost, then you need to do a pulley reconstruction, also if the patient has bowstringing. Remember, if there is injury to neurovascular bundles, either one or both, please don't do the pulley reconstruction, or if the patient has ischemic digits or a poor skin cover. And do not do the tendon grafting and pulley reconstruction at the same time, you must stage it. Right. Can you just suture remaining parts of the pulleys? No. I used to do that when I was much younger, but I realized that it was actually biomechanically insufficient. There are multiple options for your pulley reconstruction, extensor retinaculum, palmaris, plantaris as well. So there are 2 methods. There's around the bone or encircling technique and non-encircling reconstruction. Around the bone, the first one was developed by Bunnell as a single loop, and then further developed by Okutsu into a triple loop. This is strongest biomechanically, but it can cause focal bone ischemia, and then you can have phalangeal fractures from that. And you can have stiffness as well and persistent bowstringing. Here's a diagram to show how it's done. So at the proximal phalanx for the A2 pulley, you use 3 loops around the bone, and this is the strongest reconstruction, and it is underneath the extensor mechanism. At the middle phalanx, it is over the extensor mechanism because it would be difficult to go underneath the terminal part of the extensor mechanism. And for the middle phalanx, you can use 2 loops. So this is a picture of a patient with an absent A2 pulley and reconstructed using a palmaris longus tendon graft. And you use a tendon passer to pass it circumferentially. And this is what it looks like at the end of the reconstruction. This is the Okutsu triple loop. How about the non-encircling technique? This is the Kleinert and Welby technique, the shoelace weave, where you have an ever-present rim of the A2, and you use either your FGS graft or palmaris longus, and you put it through the holes in the remaining pulley. We'll show you a video shortly. This is the video by Andreas Schweitzer from Zurich. So you need to excise the scar tissue. That is very, very important. And then you should free up the remnant of the pulley on the radial and ulnar side. That's the A2 pulley. And then he is actually using an ECRL graft, which he then passes through the pulley remnant. That's on the ulnar side. And then goes on to the other side. And then you then zigzag it back onto the other side. That's your second zigzag. And you go from distal to proximal. And you may need to do up to 4 to 5 zigzags to reproduce your A2 pulley. Okay, and you will also repeat the same method for the A4 pulley if you are using this shoelace weave method. Close it, and then you just use a Dicron. Right, and there are other methods as well. The belt loop by Karaf, which is just 2 transverse incisions in the volar plate. This is actually the most biomechanically efficient because the tendon is closer to the bone. And then there's other techniques by Lister and Whitstrom, this extensor retinaculum, which is the easiest in a way to harvest and also has the least gliding resistance. So the important points, you must excise the scar wedge posterior to the tendon because otherwise you're going to get adhesions and your flexor tendon is not going to glide. Tensioning is very important. You may want to consider Wallen surgery, and Wallen will also help to educate the patient as they can see their fingers moving directly. Rehabilitation is important, dorsal blocking splint, heavy taping, and also that is a picture of a protective ring splint. Right. So in conclusion, protect the A2 and A4. At least one must be preserved. You can completely excise A2 or A4. And that is safe, and it is often necessary because gliding is very important. And reconstruct if both A2 and A4 are lost, and communicate with your hand therapist. Thank you very much.
Any questions from? So, do you, when you pass through the extensor tendon, need the extensor tendon, do you take separate incision or?
No, not separate incision. It's just the same incision. You don't have to do a dorsal incision, but you need to use the tendon passer because it's quite difficult. But you must make sure to to free the tissues underneath so that you can pass it.
From the side.
Yes.
Any other questions? Mike?
I see you mentioned the belt pulley reconstruction using the volar plate of the PIP joint.
Yes.
Have you done that ever, or because it's really only suitable for a stage tendon grafting, and also the PIP joint only flexes because the moment of inertia comes away from the joint. So if you actually hold the tendon against the PIP joint, you lose PIP flexion. And so I think it's a technique to be questioned. I think it's biomechanically good because it keeps the tendon against the PIP joint, but it then negates the flexion power of the PIP joint.
Yeah.
Comments?
For the belt and loop technique, right? Yeah, I think it says that it is as you mentioned, but I think that I agree that at the joint it's not good, and it would be better at the phalanx itself. Yeah, that would be I would agree with you as well.
Can I just ask, clinically, when you evaluate the patient,
how do you know the difference of whether that finger is not working because of bowstringing or because of a scar that you haven't released somewhere? So how do you differentiate the two? You've got passive range of motion to full, but you've got active range of motion that doesn't give you full flexion. Do you know preoperatively what you're going to do?
Okay, actually operatively, you can also do ultrasound, and when you do ultrasound, you can, if it's bowstringing, you can see the flexor tendon shadow away from the phalanx, so you know that it's bowstringing.
Thanks. We've got time for one more question, I think.
So the discussion that just happened, do I take away from it that instead of A2, we should be doing A4 pulley reconstruction?
No,
The primarily, in case of a staged tendon reconstruction, what all pulleys will you repair if
Okay.
there are pulleys are not?
if both A2 and A4 is lost, then you would have to reconstruct both A2
Both
and
A2
A4.
and-
But if there's only A2 is lost, as what I showed, you don't have to do anything. If it's only both A2 and A4, and usually the kind of conditions are in rock climbers. Those are the ones with both A2 and A4 being lost.
So A4 only is good enough, but A4 plus A2 is better.
Yes.
I think the theory is you can release the A2 if the A3 and the A1 are intact. I must admit, it goes against the grain for me to release the A2 pulley. So if there's an injury under 2C, what I tend to do is if I have to release the entire pulley, then I'll just not repair one slip of FDS or just not repair the FDS, particularly if it's in the little finger. So am I doing something wrong, do you think?
No, but if your access to the repair is difficult, then you may have to release the whole thing. And if the gliding is going to get stuck at the A2, then you would have to release it anyway.
Okay, point taken.
Okay.
Just a small addition to the question which was previously raised. How to differentiate between whether it is the bowstringing that is the problem or the passive, means the adhesions. Preoperatively, we can use a ring splint over the pulley area. And if the movements are improving with the ring splint, it is probably the bowstringing that is causing the problem. If the movements are not improving, even despite using the ring splint, it is probably the adhesions that is causing the problem.
Okay, that's a good point as well. Yeah, the ring splint.
Thank you.
I don't know if you have mentioned which type and size of suture material to be used for taking suture around the grafts.
Okay, so palmaris longus is usually the accepted choice, but but ECRL, because the thing is, if you're doing the loop, you actually do need quite a large amount, long length of the graft. If you're doing 3 loops, you may need up to, because each loop might be about 5 centimeters, you may need about 15 centimeters. Only at the A4, then you need less amount, shorter amount, or shorter lengths, basically.
Yeah. Thank you, ma'am. Thank you.
Okay, thank you.